There's a huge shortage of diabetes care professionals. People can wait months and months for an appointment. SmartStart is putting user education about continuous glucose monitoring on your phone.
Welcome to Startup Health TV, where we celebrate the entrepreneurs and innovators who are transforming health. I'm Logan Plaster. We're here at the American Diabetes Association annual meeting, and I'm here with Melissa Holloway, the CEO and founder of SmartStart. Melissa, great to see you today.
Great to see you. I always love coming to ADA, and this year is particularly special because I have a poster.
You have a poster, okay. Tell me about the poster, but first, how many ADAs have you been to before?
I think this must be number 9 or 10, but my first one I think was in 2004.
So you've been here all these times, you've built up your network, and now you're here presenting a poster for your company, SmartStart. So tell me, what is SmartStart?
SmartStart is, in a nutshell, putting user education about continuous glucose monitoring on your phone.
Okay. Why hadn't that been done before?
Honestly, don't know. I mean, that was one of the things that spurred me to start doing this, is the companies were moving very quickly to put the CGM data onto people's phones and get rid of standalone receivers, increase the follow features so that loved ones and healthcare professionals can see what's happening with somebody's diabetes data. And so the user experience became very focused on the mobile device, but the education about how to use the system and how to get the best out of it was still focused on face-to-face care. And we know there's a huge shortage of diabetes care professionals. People can wait months and months for an appointment, and the time they get might be only 10 to 20 minutes, and they might only get that a couple times a year.
So let's help folks who are not familiar with type 1 diabetes understand the challenge better. So I've got a friend whose daughter is 10 years old and has type 1 diabetes. He's very focused on that care delivery and what comes next. He's got the CGM, he understands the app, but what you're talking about is the education that goes with the app. So like, what is the experience? What types of lessons are we learning in these modules? Or
Yes, certainly. So what I like to notice is, as someone who lives with type 1, I've just had my 30th anniversary. Yes, and I hang out quite a lot in Facebook groups where I see the questions that people have. And sometimes people will say something like, my CGM sensor has stopped working, and it turns out when someone says, okay, well, what do you think the problem is? They're actually talking about the transmitter. They don't actually necessarily even know the names of the components of the system. And if they called up and asked for support under warranty, they wouldn't even necessarily get their problem solved.
How come?
Lack of someone sitting down with them and saying, this is what this is called, this is what this is for, and actually explaining it. I like to joke that those user guides, they're not just for going in a box under the bed, but truly, because a lot of the technologies have become quite intuitive to set up, people don't think that there's much in the user guide that will benefit them. And the companies are, in truth, constrained in exactly how they can explain to people how they should interpret their glucose values. There's been an assumption that the healthcare professional will be able to bridge that gap. And the truth is that's not always possible.
Okay. Does it almost feel like as the CGM technology advances and the apps get slicker, that the user thinks is maybe lulled into a false sense of security that this is it, I've got my tool, I've got my app, and maybe they aren't thinking as much about the wraparound, care that they need to get?
I think that's true, and I've also seen a lot of people express the frustration of observing a pattern but not knowing what that pattern indicates and what might need to change in order to resolve that.
Okay.
There's a sense of discouragement and a sense of, well, this is just what always happens. But when somebody can find a name for that phenomenon and hear that there's something that might make that graph smoother and make their day a little bit less stressful, then it's like the light bulb went off.
I'm fascinated that you said you spend a lot of time on these Facebook groups. It's like that is the best a lot of people have in terms of trying to get answers, just going to the community.
Exactly, and those are the people who are the most engaged. It's the most engaged people who actually type diabetes into Facebook and join a group.
Tell me about your poster. You said you're excited, you're proud that you got chosen. It's an honor to be presenting, not just have the poster, but actually presenting an e-poster, right?
Yep.
So what are you presenting, and kind of what distinguishes it, what made it rise above the rest?
Oh, thank you. So this poster is the proof of concept study data for SmartStart CGM. And the study started in September 2022 and completed in September 2023. It took us a while to recruit because the doctor I was working with on it was very busy with increasing levels of travel and et cetera. But we got there. We got our 20 patients in. And what we found that was most remarkable is that not only did their knowledge score on a 20-item assessment double from baseline to completing the modules, the time in range change was something that I was astonished by. I thought, oh no, that can't be possible. And I ran the numbers again. At the beginning, when they first started, the doctor logged their time below range and their time in range. We had only 30% of the people reaching both the time below range goal of no more than 4% and the time in range goal of 70% time.
What's the type of education that they're receiving that's helping them keep their glucose in the range?
So in this doctor's practice, and he's a very committed professional, he lives with type 1 himself, has used CGM for several years. He is a leader. So this is a good standard of care. This isn't a place where they're really struggling and they know that they can't provide the care that they wish they could to their patients. Face-to-face appointments with diabetes educators, a bit of phone follow-up, and probably 3 to 4 appointments per year for quite a few of those folks because they had good insurance. And a lot of his population lived pretty close to the clinic, so it wasn't as if he was in a very rural area. He was in a city. Okay. Not a very big city.
Good standard of care.
Yeah.
You layer on SmartStart.
Yeah. Just as an extra bit of info on here, most of those folks were also using an automated insulin delivery system. Okay. So they had the best in class, not only a pump, but the pump that would connect with their continuous glucose monitor and make automatic adjustments to help improve their time in range. So with the gold standard, best in class insulin delivery systems, we still had not everybody reaching those goals. And that is a phenomenon we've seen in the trials of these devices. There's still, even with the best technology, there's still an amount of behavior and self-management that will make them really work as they could. Okay. Right? Okay. And sometimes people have learned behaviors about how to manage their diabetes that are difficult to unlearn. For example, when I was diagnosed, it was very important that I had a bedtime snack because of the risk of having a low blood sugar overnight and on that insulin regimen. But when I changed onto a pump several years later, I needed to unlearn that because the pump wasn't going to give me the same risk of having a low blood sugar at night. But I met people who'd say,
but you still wanted that snack.
Oh yeah, it was part of my routine. And over the years, in terms of my advocacy stuff, I'd meet people who said, they said going on this pump was going to help me so much, but my blood sugar is always high in the morning. Do you have a bedtime snack? Well, yes, of course I do. Why would I not? Yeah. Do you take insulin to cover that snack at bedtime? Well, why would I do that? I'm taking the snack so that I don't have a low at night. And then to watch the light bulb go off that, oh wait, hang on, I'm putting my blood sugar up at night because I'm eating a snack and not covering it with insulin. So yeah, my pump is keeping my glucose level steady and above target all night.
So the problem in that scenario is that they received the new technology, but they didn't have the wraparound education that is necessary. They're just getting quick touch points with their endocrinologist or their diabetes educator, just a minute here, a minute there, and they need to be educated more fully.
Well, yeah, and it needs to be targeted to the capabilities and the behavior changes that are necessary to make the most of whatever the tool is. Okay. So actually thinking, okay, let's talk about how you currently manage and what might the behavior changes need to be in order for you to get the best out of the system.
Now quickly connect that back to SmartStart for me. How are you actually helping them do that work better?
Yeah, so by using storytelling and showing pictures of characters' glucose profiles and then the decision points that they have in the course of this story about what they're having to deal with. Okay. So for example, there's one about exercise, and let's imagine Dawn is going to do an insanity workout a few days a week after work. And she's going into her workout. This is what her glucose trace for the last 3 hours looks like. Should she have a snack or not? Why?
Are these quizzes?
It's an interactive quiz.
Okay. So in an app or on desktop?
Sitting on a commercially available learning management system that looks great on a mobile phone. So Euricos LMS. Okay. I needed to use a commercially available system to do this proof of concept because I didn't want to invest a ton in coding, only to find out that actually there were some major issues with the content.
Okay.
So now I know there's no issues with the content. I'm gearing up for the next phase of technology with introducing adaptive learning. But in this proof of concept version, I just wanted to see if we tell the story and we give people the feedback on the choices the characters might make, how does that stick? One of the things that I feel is true is that phrase, people don't always remember exactly what you said, but they remember how you make them feel. And why do we read novels? Because they tell us something about the human condition. They tell us something about people who might be very different from us, or we might be able to relate to them in some way or other. So by using characters who are going through the daily stresses and the moments of indecision and trying to solve their own diabetes challenges in the course of something that takes like maybe 5 to 8 minutes to read and to interact with, there's an emotional connection, which is going to help the information stick better in terms of the techniques of behavior change. Okay.
Are these illustrated? Are these kind of built out as like full stories?
Well, when I say
case
full
studies?
stories, they're case studies, but each one can be done in 5 to 10 minutes.
Okay.
So the modules themselves, there are 7 total content modules, and we found in the proof of concept that people needed an average of 90 to 120 minutes to complete all the modules. And by seeing the change in the time in range, we thought, well, actually, in the same time it takes to have a few diabetes appointments, if you include driving or taking transport to the clinic, parking, and being in the waiting room, all of this, we seem to make more of a difference in how people can manage their diabetes successfully.
How do you feel about the fact that you're at the ADA, you've been at conferences like this for many, many years, there's always new technology, there's all these innovations, and sometimes it's something as seemingly simple as telling a story, showing somebody visually what it would look like to change their behavior. You're not talking about some new drug, you're not talking about, and yet this often is the kind of innovation that's necessary to change behaviors. I mean, I don't know, do you have any thoughts about that and kind of how what you're doing fits into the larger landscape of tech innovation?
Great question. So the human touch is often perceived as what happens in a face-to-face environment, not necessarily what happens to support somebody when they can't access their healthcare professional. There's a graphic that's been used in diabetes for about maybe 15 years now that shows the UN Unite for Diabetes blue circle with a little tiny wedge missing. And the person who's using that graphic will usually ask a big room of people at a conference, does anyone know what this represents? And wait for the response to say, oh, isn't that the Unite for Diabetes symbol? Like, don't we all know that? And then the punchline is actually close. But if you take a look at this little sliver up here, that little sliver represents the time that somebody with diabetes actually interacts with their healthcare professional in the course of a year. So what can we do to support people in those moments when they're not in front of their healthcare professional? Beyond that, I think there's a lot of nodding and smiling that happens in real life because we all love to show that we're doing it right now. We love to show that we're doing active listening. And in terms of how people live with diabetes, there's a little self-consciousness of not wanting to seem like they don't know what's going on in that interaction with a healthcare professional. So I see among those very engaged people that I mentioned who do show up on Facebook, sometimes there will be a post like, I went to my diabetes nurse appointment and she said something about, and then there's this kind of confusing series of words, and I think, well, I don't know what she was talking about either, but clearly something has gotten lost here. And I say, okay, well, did you ask her at the time if she could clarify that? Well, no, I wouldn't want her to think I was stupid. Well, when's your next appointment? 4 months. Okay, so you might have to send an email and say, there was something that you said, I caught this bit of it, can you please give me a link that I can follow up? But that's a big step for somebody to have to take, and that's an extra step in that healthcare professional's day. So it doesn't often happen. So thinking about why do these innovations really happen, and well, why does it have to be me as a patient who drives it? Probably because I'm in those environments seeing what people are looking for in terms of connection and sharing with each other what works for them, and thinking for the people who don't have that community and aren't feeling like they can enter into it, or worry that they might actually get advice that's not helpful or which is indeed harmful, creating a tool that healthcare professionals can use with their patients is a way to provide relief for the healthcare professionals, some reassurance for the people who are moving with the technology, and hopefully improve outcomes for everybody.
Okay, quick final question. What are you excited about what's coming next for SmartStart next 6 to 12 months?
Big focus is going to be on realizing my dream of incorporating adaptive learning with some machine learning algorithms, so that we can tailor each person's journey to where they're starting from, what type of treatment they're on, what their personal goals are in living with diabetes and using their technology. And I'm incredibly excited to see what we can do. Just seeing what we could do with a non-adaptive learning path makes me think that the future is wide out there.
Awesome, awesome. Melissa, great to see you. Excited about what you're building. Excited that you're presenting it here at the ADA, and we'll be watching closely.
Thank you. Cheers. Enjoy yourself.
Thanks a lot.